At Lumibird Medical, innovation is at the heart of everything we do. From precision lasers, ultrasound devices, and cutting-edge diagnostic tools, we empower ophthalmologists worldwide with the technology to deliver exceptional patient care.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Vivienne Hau. Dr. Hau is a clinical assistant professor and vitreoretinal surgeon at the Kaiser Permanente School of Medicine and a board member of the American Society of Retina Specialists. Dr. Hau, thank you so much for joining me today.
I really appreciate you inviting me to be a part of this. I think it's a great effort that you do for education in general for the entire field.
Thank you. So I know that I am going to learn a lot this episode from you. So let's jump right into the case here. So this is a 56-year-old man with a history of hypertension and type 2 diabetes who presented with a slow decrease in vision in both eyes. His best corrected visual acuity was 20/50 in the right eye and 2200 in the left eye. You did not note any neovascularization of the iris or the angle, and there were mild nuclear sclerotic cataracts in both eyes. On dilated examination, the patient was noted to have dilated and tortuous retinal vasculature, scattered hemorrhages, cotton wool spots, hard exudates in both eyes, greater in the left eye than the right eye, and then with evidence of neovascularization of both the disc and elsewhere in the left eye. So that is a mouthful, and it seems like this person kind of has every single thing you could imagine on their dilated exam. Before we jump into the details of management, can you review the diagnosis of non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and then proliferative diabetic retinopathy with high-risk features? Like, how do we kind of categorize those three things in our minds?
Yeah, that's a really interesting case that you presented there and something that I see commonly almost on a daily basis. And so this is a great case to go over and kind of illustrates all the different aspects about diabetic retinopathy. As we all know, diabetic retinopathy is the leading cause of vision loss worldwide, especially from the ages of 25 to 74, basically of working age, and certainly is on the rise. And so important that as ophthalmologists, that we definitely know how to recognize it early on and understand the high risk characteristics so we can treat them early on and know how we can triage them, especially to retina specialists if we have to. Now, basically, when you look at diabetic retinopathy, just remember what is going on. I mean, in essence, these patients have elevated blood sugar. What does that mean? With the elevated blood sugar, it's toxic to the endothelial cells of the blood vessels. They cause advanced glycolylated end products. Basically, the sugars, they bind lipid and proteins. And when they form those byproducts, those are biomarkers for a whole slew of all sorts of diseases in the body, including Alzheimer's, cardiovascular disease. But for the purposes of this discussion, it's going to be diabetic retinopathy. So if they're damaging the blood vessels, what's happening? The blood vessels become leaky. They start to bleed. They start to, they basically don't have good blood flow, which means they don't have good oxygen. So when all that is happening, you're having issues like ischemia. You're having leakiness, so you're causing swelling around the area. So if you think about the pathophysiology of what's going on, you can kind of understand how diabetic retinopathy occurs. And if you think about non-proliferative versus proliferative, it's all basically a spectrum of severity. So just going back to just in general what's happening to the vessels as they're being damaged, you're having basically of three major primary concerns. One, you have capillary leakage. Two, you have capillary occlusion. And three, it's whatever happens after the retina ischemia, which could lead to retinal neovascularization, vitreous hemorrhages, tractional retinal detachment, neovascular glaucoma, and whatnot. So now that you understand that general pathology of what's happening, let's break it down into non-proliferative diabetic retinopathy versus proliferative diabetic retinopathy. And basically the main difference is the whole key. proliferation. Proliferation of new abnormal blood vessels. That's the main difference between the two, NPDR versus PDR. Now, let's look specifically at NPDR. At NPDR, you can break it down to mild, moderate, and severe. And so for all of you studying for OCAPs and trying to understand, this is so important, even some med students as well, because this is just, you're going to be asked this stuff every single time. So you got to know this like the back of your hands. And if not, your professors are going to always ask you questions about this. So mild, basically few microaneurysms around the retina. And basically all those are is that the endothelial cells of the blood vessels are so damaged that they can't maintain their overall morphology. And so they have small little outpouchings in the capillaries. Those are microaneurysms. Those are, so if you have so mild NPDRs, when you have a whole bunch of those, but not much more beyond that. Now, what happens when those microaneurysms are more severe? They start to leak and bleed. And where are they located? They're located within the retina itself. So when they leak and bleed, they're kind of localized in a little area. They form little circular spots. They look like dots. And that's why we call them dot and blot hemorrhages. So now you got microaneurysms and dot and blot hemorrhages and more severity. And then if they're not getting enough blood flow because these blood vessels are damaged, then you're not getting oxygen to the area. And so then the surrounding tissue responds by swelling and maybe getting a little bit and getting ischemic, and the color changes. So they look like little cotton wool spots. So now you got cotton wool spots, you got bleeding within the retina itself with dot and blot hemorrhages, and you got those outpouchings called microaneurysms. And then finally, if it's bleeding a little bit, it's leaking a little bit, sometimes that leakage, that fluid that leaks out, it gets reabsorbed, and what's left over, the sediments. And that sediments are hard exudates, basically lipids that are left over after the fluid has dried up. It's kind of like when you have hard water stains, in the shower, and you're left over with some of those little bit of calcification. That's what the hard exudates are like. So now if you are having evidence of all those things I just talked about, microaneurysms, dot and blot hemorrhages, cotton wool spots, and hard exudates, then you have moderate NPDR. Now, moving on to severe, that's something that's called the 4-2-1 rule. Okay, 4-2-1. So 4 quadrants of diffuse retinal hemorrhages and microaneurysms. So if you just look at the retina and you break it up into 4 quadrants, you got it everywhere. And then you have 2 or more quadrants of venous beating. So basically the blood vessels almost looking like sausage linking or something like that. You see them beating within the venous vasculature. And the 1 is 1 or more quadrants of intraretinal microvascular anomalies. Basically, they're abnormal vascular findings in at least 1 quadrant or more. So that breaks it down into mild, moderate versus severe. Now, there's been some suggestion that treating some of these patients at the severe level can help with the progression earlier on to PDR. So some people actually might recommend using anti-VEGFs, and there's been some studies that have looked at the potential of treating some of these patients, but some will choose to monitor, and that is also standard of care, but they need to be monitored very closely because they're at high risk of moving on to proliferative diabetic retinopathy. Now, PDR, as I mentioned, is when you start having proliferation of vasculature abnormal new blood vessels that are formed. They're so ischemic that the body is trying to fix that ischemia by making new blood vessels. That's called angiogenesis. And that's when then the areas where you see this form, these new blood vessels form, you're going to see it either in the disc, that's called neovascularization of the disc, on the iris itself, that's called neovascularization of the iris, and neovascularization elsewhere, which basically is anywhere else in the retina itself. Now, as a end problem of neovascularization of the iris, it can grow into the trabecular meshwork, the drainage system of the eye. And if it clogs up the trabecular meshwork, then you can have neovascular glaucoma. So pressures can go sky high and can really just damage the optic nerve, which is, of course, all sorts of badness. Now, how do you diagnose proliferative diabetic retinopathy that's high risk. The high risk characteristics are when you have neovascularization of the disc of greater than a quarter to a third disc area, or if you have any type of neovascularization of the disc, even if it's smaller than that, but associated with any sort of vitreous or preretinal hemorrhages. Or the third criteria would be any neovascularization elsewhere. So in the retina, somewhere else, is also associated with vitreous or preretinal hemorrhages, basically hemorrhaging into the vitreous space underneath the hyaloid space. So then you have preretinal hemorrhages itself. And so then you have to be really concerned because, what is blood? Blood is very inflammatory. And when something's that inflammatory, it can lead to scar tissue. And if you got scar tissue forming, scar tissue contracts, can pull up on the retina, cause traction, can cause holes. Then you've got retinal detachments, and then of course ultimately blindness if you don't take care of this sooner than later. So there you go. Those are the difference between NPDR, PDR, and the different types.
That's so helpful. And I really love how you work through the pathology behind each and like all of the different pathologies that explain the clinical examination findings. That's super helpful to help remember what you see and why you see it. So let's take a few steps back. What would you want next in the workup of this patient? What would be your next steps once you have this exam? You've talked to this patient a little bit. What are the essential need to know?
Of course, nothing replaces the best part of the examination, the most important part, and that's of course your overall clinical examination. Remember, people are diagnosing this stuff even before the advent of optical coherence tomography and things. So sometimes we got to remember, there are times when your machine might be down. You just got to make sure you understand and how to recognize things with a good clinical exam. But of course, aside from that, we've got these amazing diagnostic procedures today that help us in our diagnosis. And as I mentioned earlier, optical coherence tomography, OCT for short, is a great way to do essentially a virtual biopsy of the retina. So you could actually look at the various layers of the retina itself. And you can actually determine where the fluid or bleeding is occurring using the OCT. So you can see if it's intraretinal or subretinal fluid. You can see how thick the retina is. And you can measure the central fovea thickness and follow it over time. So this is really especially important when you're looking at the leading cause of visual impairment in people with diabetic retinopathy, which is due to diabetic macular edema. And this is a quick and easy way to take pictures of the person's eyes imaging and follow over time because it's not very invasive. Now, the gold standard, which I always get of any patient that's brand new to my clinic and concerning for diabetic retinopathy, is fluorescein angiogram. And what this is, it's an active dynamic test where I can evaluate how the blood is actually flowing through the blood vessels, through the retina over time with sequential serial images. And so with an OCT, you don't do that. It's just a static image at one time, and you don't see the flow and presence of fluid, whereas you can see that with fluorescein angiogram. And so when you're injecting a dye into the person's vein, it flows through the vessels of the back of the eye, and you could see what vessels are being lit up by the fluorescein dye. And you can tell which ones are not flowing, which ones are flowing, and areas that are specifically leaking. So as I mentioned earlier, in people with proliferative diabetic retinopathy, they have abnormal new blood vessels, and these are very fragile. And you could tell which areas have formation of this because they'll cause a cloud of fluorescein on imaging. And you could tell that specific area of leaking. That could be an area you might want to target for laser cautery, or just having a general idea of what's going on. And you can also see microaneurysms, like they look like a starry sky at night because you see all these little white spots that light up the retina. But I mean, that's a great thing to do with anybody with retinopathy, fluorescein angiogram, and optical coherence tomography. We have some newer types of imaging like optical coherence tomography angiograms, and that can also give you some more information in terms of the anatomic areas of the eye and the different layers and looking at the capillaries and vasculature and the changes over time. But in general, that's not essential to the overall management. I think having an OCT and FA is essential for evaluating and managing these patients over time.
So you mentioned macular edema and the leaky blood vessels. Let's say that you completed the workup and you noted diabetic macular edema in both eyes. Can you tell us a little bit about how you would guide your treatment? When do you choose photocoagulation over injections? And when do you decide to take these patients to the operating room?
Now, those are great questions. Now, the way I think about laser versus anti-VEGF, anti-VEGFs are immediate. They work like pretty much right away as soon as you inject the eye itself. And so if I've got somebody who's got some significant vision loss from diabetic macular edema, I want to try to treat that as soon as possible. And that's why I'm going to hit them with an anti-VEGF therapy right away, or consideration of corticosteroids. Now, the thing is with these pharmacologic treatments, they are not long-term. They all have a certain half-life. And most of them last maybe about 1 to 2 months. We have some newer ones that have recently come out, and they've been shown to last as long as 3 to 4 weeks, which is fantastic. However, not in everybody. And so a lot of these patients need to be seen on a monthly basis to be evaluated with serial OCTs to see how the swelling is going down or improving or not. A lot of times I'll start off with an anti-VEGF because, as we all know, with folks with diabetic retinopathy, they have increased presence of VEGF. And so you want to try to attack that as soon as possible and bring down their load of VEGF with anti-VEGFs. Now, after you hit that pretty well, though, there's also an inflammatory component that we see in a lot of diabetic macular edema as well. And that's where corticosteroids can come in too, in combination with the anti-VEGFs to bring down the swelling in cases that are recalcitrant to further anti-VEGFs. Another type of treatment, as we mentioned earlier, was laser. You can do focal laser on these patients as well, but the laser takes time for it to really work well on these patients. It's not an immediate thing like the anti-VEGFs or corticosteroids. And so once you get the swelling down as much as possible, then you might want to consider doing laser treatments, doing focal laser on some of these areas of macular edema, because you'll have a better effectiveness if the swelling is down. If it's too swollen, then they won't be as effective. And the laser, for it to really have its maximal effects, is going to take time over the next few months, like 2 to 3 months, for you to really see the maximal effects. So you can use that in combination of everything, once you get the swelling down with the initial treatments of anti-VEGF and corticosteroids. So that's kind of how I mostly approach the diabetic macular edema patients. Now, what's really interesting, I just want to mention also, is I should give some credit to the Diabetic Retinopathy Clinical Research Retina Network, the DRCR. This is a group of multiple sites that have done a fantastic job in looking at the management of diabetic retinopathy in a lot of our patients. They're doing the kind of studies that a lot of pharmaceutical companies wouldn't do because it's not financially good for them. And so these are studies that are done by ophthalmologists, by retina specialists, for retina specialists that are not as affected by pharma money. And so I feel like this is in many ways the purest form of doing clinical trials. And what it is it's a bunch of ophthalmologists who are getting together and trying to answer some questions in terms of how to treat diabetic retinopathies in the best possible way. So you may have heard about some of these protocols that you've talked about. And one of the most significant ones is Protocol T, where they're able to show that all 3 major drugs at that time, which was bevacizumab, ranibizumab, and aflibercept, are effective for macular edema therapy with very similar outcomes in eyes with pretty decent vision. And then they had shown that maybe that there was some better potential with aflibercept when eyes that were 20/50 are worse versus bevacizumab and ranibizumab versus at year 1 and 2 or year 1 respectively. They've also looked at other type of studies, and I think one thing I should also mention is just because there's diabetic macular edema doesn't mean you always want to treat it right away. So they also showed in Protocol V that in patients with good visual acuity, 20/25 or better, that it's actually okay to watch and observe these patients, even if there's a little bit of diabetic macular edema you're seeing on OCT, because they do well with observation. And so, but you want to watch them closely and treat if it worsens or if it gets worse. The way I like to look at this too is in the real world, if a patient comes in with 20/25 or better and you see macular edema, chances are they're not complaining of their vision. And the last thing I want to do is inject them with something and potentially cause something like endophthalmitis or cause even something simple as like a subconch heme or something, or soreness of the eye, when they're like, Doc, I didn't feel like there was any problem with my eye in the first place. So these are situations where you have to kind of think about, just because you're macadema, you don't want to treat, you want to don't want to try to fix something that ain't broke just yet. Remember, you're treating the patient, you're not treating the pictures. And so this is a simple case to always remember. You treat the patient, what they need at that time. And just because the pictures might show something, you don't necessarily have to treat it. And Protocol V has shown that you don't have to treat it right away. And so that kind of explains how I mostly approach patients with diabetic macular edema. Now, I think one other thing to add is maybe when would you want to do surgery for some of these patients? And so some of these patients, you may see some vitreomacular traction. That's when you have the posterior hyaloid pulling upon the retina itself, or maybe there's a fibrovascular membrane causing an epiretinal membrane or causing some traction upon the retina. So then now it's not just an issue with leakage from the blood vessels. There's also a mechanical issue pulling on the retina and limiting the ability of the macula to go down. And so then now you have to remove the mechanical component. And that's when I would consider doing surgery at that time. And especially if there's other areas of scarring or scar tissue that's forming, and I want to get to it before it causes more traction, and maybe put in like a whole bunch of laser, because when you're doing surgery in an eye, it's a great opportunity to really laser the peripheral parts of the eye. Because where is it most ischemic in people with diabetic retinopathy? Where do they have the worst ischemia is in the peripheral area first before it moves on to the central area. And so it's really hard to get when you're trying to laser in the clinic. But if you're doing that under surgery, they can really get the endolaser out there in periphery. And so that's another benefit of doing surgery as a secondary helpful thing when you're doing surgery for somebody with diabetic macular edema.
I love that. Two things that you said. Number one, just listening to our patients and really understanding their needs. Like, we absolutely do not want to go chasing a 20/25 eye in a happy patient. So I think that that's something that, especially as young surgeons, we really, really need to keep in mind. Just because we see a pathology doesn't mean we need to chase it. And then number two is that you kind of already started talking about your surgical approach for these tractional patients or patients with scar tissue. And I love that you talk a little bit about the lasers in the periphery. Are there any other surgical pearls that you have for these patients? Anything that you do differently or you need to think about in the postoperative period for your diabetic patients?
I think a lot of these patients, I mean, you have to remember these patients came to you because they've been non-compliant about their diabetes, for much of their life. And so you have to really impress upon them before and afterwards that they really need to be good about staying on top of their post-operative care, about coming to their appointments, because just because this is not a one and done quick fix, this is something that's going to be a long-term uh, treatment relationship with you as the doctor. And so I tell all my patients, if you want me to get you better, we have to enter into an agreement where it's a partnership. And you've got to hold up your end by controlling your blood sugars, coming to your appointments, bringing down that hemoglobin A1C, and just being better about your diet overall, and going to see your family doctor as well. While I will do all I can to help you with your vision, but I can't do it alone. And so that is something that I always make sure that is very clear before I jump into any sort of treatment with my patients, so that the postoperative outcomes can be the best possible for everyone associated. The other thing is, remember these patients, they have leaky, fragile blood vessels. So you have to remember, a lot of these patients will sometimes bleed postoperatively, not because you did something wrong during surgery, but it's just the nature of their blood vessels. So it's normal for them to have vitreous hemorrhage. Also, it's also normal for these patients to have early cataracts because of their condition too, which is associated with diabetes. And so if the patient hasn't had cataract surgery yet, I always tell these patients, don't expect an immediate perfect outcome of your vision. And your vision day one or day 1 month or 2 or 3 months may not be your final vision, especially if you haven't had cataract surgery yet, because your cataracts may progress over time. And then two, you may have postoperative vitreous hemorrhage because of the leaky blood vessels. And so we have to be patient about the improvements. And so making sure you spend time with the patient ahead of time so that they have proper expectations for the postoperative outcome. Not that it's all of a sudden going to be perfect the next day. I think a lot of patients, for some reason, because it's the eye, they just think everything will be perfect the next day. Versus if they had surgery, like open heart surgery, they're not going to expect it to be perfect next day. But somehow for the eye, even though it's major, it will be. So it's really taking that additional time and explaining things to the patient. And I find that whenever I do that, the outcome's so much better. The patients come to their follow-ups and are not as non-compliant as they used to be. And I always tell them, remember, with diabetes, it's a long-term treatment relationship. But the key is that you're not going to be doing it alone. I'm going to be there with you the entire time. But you have to let me be a part of that by taking care of yourself and coming to your appointment.
It's so true. I love that. I love that you frame it as a partnership because that's truly what it is. And then I was just thinking when you were saying that you try to set the expectations, especially when it comes to vitreous hemorrhages. And, we always hear that adage, I guess it is, but like that saying of surgical outcomes equal reality minus expectations. So you never want to overpromise something because then their reality is less than their expectation and patients can get really upset about that. But kind of being realistic with them, setting those expectations early allows patients to understand and to anticipate what's going to happen in the postoperative period. So just circling back to surgical indications in these diabetic patients, what are, other than tractional retinal detachments and scarring, what are some of the other major indications for taking our diabetic patients for vitreoretinal surgery?
That's a great question there. Again, there's actually several situations where I might want to jump on a patient earlier than later. Now one thing you remember, a lot of these vitreous hemorrhage in patients who have long-standing diabetic retinopathy and they've been known and they've already had a bunch of laser done back there. These are not necessarily urgent sort of situations. And so again, these are patients I counsel them and letting them know so they don't get anxious that if something happens on a Saturday night, they need to rush in and wait 8 hours in the emergency room to have to be seen because they're going to go by. It's like, no, I remind them that back in the old days that sometimes we would wait for the blood just to clear on its own before we actually did something, before the days of anti-VEGF. Now, that's not saying we should do that today, because obviously we have treatments that can treat them earlier and later. But along with that, what I'm saying though is, what if the patient only had one eye? If they're a monocular and that's their only good eye that they have, and they can't see out of it, and they're having a lot of difficulty in ambulating or taking care of themselves, then I might want to consider going in sooner than later, as long as they understand the risk of doing surgery and the risk of doing surgery in a monocular eye, because obviously if something goes wrong, then that's going to be the outcome's going to be very very awful. But usually for patients where the blood has been in there for a while, despite all the injections I've done, after about 2 or 3 months, and non-clearing vitreous hemorrhage, that's a situation when I might then offer surgery for the patients if they're open to it. The other thing is, maybe they've already had a bunch of laser back in the eye already, but they keep bleeding over and over and over, and they have to come in for these injections over and over. And maybe it's becoming a big burden upon their family to have to drive them in, or having a big issue with their work. Like I had one patient who would travel all the time, all around the country, doing work where he'd be gone for months at a time because he was somebody who did remodeling of hotels, and the projects would take months, and he was the person in charge, but he had bad diabetes. And so sometimes it would just be easier. Hey, doc, I'm here for 2 weeks. I need something done because you know it's going to bleed again in the next few weeks. So that's a situation where I might be like, okay, let's get you in. We're going to monitor you, watch you closely, and and maybe do surgery sooner than later for you. So it depends again on the patient selection and their needs. If there's a lot of blood back there too, if it's sitting there for a long time, especially if it's premacular subhyaloid, that can cause scarring back there. And you can't see the macula, especially over the macula underneath. You don't know what's going on back there. So that might be something you also want to get to sooner than later if it's not clearing effectively. Sometimes when you have a vitreous hemorrhage and you're treating it and everything, but it's just not clearing, and then you could lead to something like called ghost cells, and that can get into the trabecular meshwork and cause high elevation of the intraocular pressure, and sometimes you just need to clear that out before there's further damage to the optic nerve. And so those are cases where I might want to take them in sooner than later as well and do surgery for. And I think a lot of those are sort of the main reasons. I'm trying to think if there's anything else. I mean, obviously, if you're worried about maybe traction's so bad that it caused some holes and you got a regmatogenous thing going, and especially if it's getting close to the macula, that's something you also want to get to sooner than later as well. And then also if there was really bad um, neovascularization limiting your view to the back, then you also want to get into sooner or later to give them adequate PRP before it causes all sorts of problems back there as well. So those are some other indications why I might want to do surgery as well.
Amazing. I think this was such an important episode. We have so many patients with diabetes. Those numbers are only going to continue to increase. Our hope would be that we can see these patients early on, but it's becoming a bigger issue in lower middle income countries. I work in different countries around the world this year, and that's one of our biggest challenges. You have these communities where they don't have access to the same dietary choices, dietary ingredients that we have here. And oftentimes they develop this severe diabetes and we don't have retina surgeons. And some places that I work, we don't even have lasers, and we definitely don't have anti-VEGF therapy. And so it's a lot of counseling, and it's a lot of hoping that they can keep their hemoglobin A1C and their blood sugars down in an attempt to just slow progression as much as possible. So we are lucky that we have surgeons like you and facilities that we do here.
I love what you shared about working in other countries and the limitations that you might have. This reminds me of a quote that I once read. When the surgeon does not have his surgical instruments in hand, his or her words becomes their tools. And so, like what you're saying, we are educators, and first and foremost, that is what we need to do before we jump in and do anything in terms of any types of treatments or surgeries, is educating, using our words to let them know what's going on and how they can take care of themselves. So I appreciate that experience that you have. Sometimes we forget that, being here in America with access to all the tools and pharmacological treatments that we have because we're a first world country. But in the end, we still need to teach, and that's why we need to spend time in the offices with the patients to let them know what's going on and how they can take care of themselves.
That's really beautiful. I love that quote. And sometimes, as helpless as we might feel when we don't have those surgical instruments, we really do have a lot of power in our words. So that's something to definitely remember. Dr. Hau, thank you so much for joining us on this episode of the Pupil Pod. It was really my pleasure.
I had a great time. Thank you so much for inviting me. I'm honored to be a part of this. I think what you guys are doing is such a fantastic thing that I wish I had when I was going through training. But again, thank you for this opportunity.
And thank you to those tuning in. See you next time on the Pupil Pod.